Thank you, Brett. That was perfect because it really brought us back to the perspective of the patient in all of this structure and raised the additional questions. You heard a lot about the model for the federally qualified health centers and all of the supports in the Affordable Care Act to make that a very important model. You heard Peter's thoughts about perhaps that model and the hybrid models being the successful models of the future in a healthcare reformed environment. And then you heard from Brent on the real challenges of serving complex patients who have both these incredible clinical needs, but also these social needs that need to be built into a system that includes fragmentation, that today includes fragmentation. Is there a way for us to change that in the future? Is it going to be through FQHCs? How do we bring the clinicians to bear who can really serve that population, regardless of what the organizational structure? So we have many, I think, important questions that the panel has raised. We're going to take questions and comments from the audience now for about 20 minutes, and then we're going to bring the reactor panel up to give their reflections on what they've heard from the panel, as well as what you might bring up in the session. So we have two microphones, Patrice here, and she will bring it to you, and Heather on this side, and they will just alternate. So Patrice, I think you have one right there. And then we'll go over. I know you wanted. Then we'll go to Jane after that.
Thank you. I'm Dave Law from Joyce Southfield Community Development Corporation in Detroit, and we operate both a free clinic, but we also have community development programs. So we're trying to broadly target health determinants. And I just want to share a comment. I think Peter's comments were really well taken about the ability of a free clinic to adopt the patient-centered medical home model. And what we've done instead, we've developed a patient-centered medical shelter, and we've tried to identify what are the key factors that will allow us to have an impact on health outcomes. And so in our demographics, we're talking, food deserts, recreational voids, poverty, stress. So we're trying to say, what can we do to mitigate the complications of common chronic diseases like type 2 diabetes, hypertension, asthma, and so on. And it's actually turned out to be a pretty effective model. We can, again, as Peter pointed out, high ROI. We use a lot of preventive education. We use disease management. We use telemedicine. We use engagement, respect, forming long-term partnerships with our patients. And then the other thing we've done is we've adopted health IT so we can measure outcomes very efficiently. It's actually a program developed here at U of M. So you can really get these low-cost, high-quality interventions. They're not going to deal with all the challenges that are out there, but they're a good stopgap. And we can, and then by doing referrals and collaborations, we can deal with some of those other issues as well. But it's a pretty good model. I'll be happy to talk to people later on about it.
That's great. All right, thank you. You want to go to Jane?
Thanks, Patrice. Just a comment after Brent. Jane Zwiers from the Free Clinic of Kalamazoo. I've been a nurse for a long time. But Brent, I have a question for you in your in how you describe the uninsured. I'm trying to understand what your vision or your image of the uninsured are. In 17,000 visits at the clinic in Kalamazoo, the uninsured aren't, in my experience, don't fit sort of, some do, but a small portion of them do fit into the category of the complex care clients. There are certainly some, but the vast majority of the uninsured that we have seen are people who are really quite capable of caring for themselves, respond to persistent and continuous reinforcement, health education, and information, and have moved out of a free clinic into a medical home as it has become available and providers have been hired. So I think there's always, in 17 years, I think that there's always a place for somebody to say, wait a minute. The uninsured are not necessarily the same population that come to the door who have the kind of complex, difficult scenarios that you've shared. Obviously, these clients remind me of downtown Chicago, Press St. Luke's, across from Cook County, day after day after day. But that is not the same population that many of us in free clinics have been caring for and engaging. So I don't know how to, I'm not asking a question, I'm just saying, I think you need to think about that a little bit. Maybe in your experience, in your specific area of complex care, I understand that you're seeing difficult clients. The uninsured, in my experience, have not been difficult clients for the most part.
Let me be clear. I apologize for not being clear enough.
Okay.
The majority of I use the word outlier, if you'll recall. So the majority of my comments were about outliers. That first slide about high utilizing,
Right.
low income, under and uninsured patients. It's a minority of patients. You're absolutely right, and let me be I'm worried that your misconception of what I was saying is widespread, because it would be a tragedy. To be very specific about this, and at the end we talked about that the modal patient, the majority of patients, are likely to find effective homes, effective care in the patient-centered medical home. To put specific numbers reinforcing the importance of what you're saying, we screen the discharge summaries of every uninsured, low-income, or underinsured Medicaid patient discharged from the University of Michigan hospital and emergency room. About 80% of those are doing fine. About 15% of those require short-term support to get transitioned back into the services. These folks comprise 1 to 5% of the patients that are discharged.
But big dollars.
Exactly.
Big dollars.
Which means, and I brought them to the table here not only because they're complex, but because of the big dollars. They will play an important role and attract the attention of administrators and designers of the system.
Well, there's just no question that primary homes managing level 1 and 2 depression is key. Absolutely key. If a primary care doc can manage the level 1 and 2 depression, it's huge. It's just huge.
Right.
And repetitions worked really well.
Jane, I don't want you to lose the mic because I want to ask you a question, but I just want to echo something that is really a takeaway from the conversation you're just having. Vern and Kim and I were involved in a discussion yesterday about the future of Medicaid, and the Medicaid HMOs in the state were totally focused on this population that Brent talked about and wanted to have a solution for this population.
Fix them all.
For the same reason you just said, they're the money, and they're so challenging to deal with. But they don't represent the majority, and I think you're right.
And the uninsured have gotten such a bad rap.
Yeah.
You know, bless their pea-picking hearts. They're just trying to get up and out. And the ones that want to and can are moving out.
That's right.
So how to support that, as well as doing the constant repetitive over and over and over and over. But it does make a difference.
So before you give the microphone back to Patrice, could you, since you just really made a very major decision in Kalamazoo, can you just say a word about what you've done in your community that speaks to the future and why you did it and what the changes?
Well, I think we have found, again, our model is very different. We have not attempted to be a primary care medical home for the 17,000 non-duplicated individuals we've seen over the last 15 years. So 50,000 visits. We have been referring to the Federally Qualified Health Center for all these years. But with new leadership there and with a real concern to know whether we were greasing the skids effectively and actually getting the clients into the home, into a medical home, we made overtures and visited Denise and Tracy at the Family Health Center. And instead of fighting with that entity, which I had polished my skills at doing, gave up on that and said, wait a minute, maybe this could look different. And with Denise and Tracy, it's just been a match made in heaven. I mean, it's just been a really wonderful learning time for all of us. There's been resistance with some of the staff at the clinic not wanting to give up their jobs. That's been a biggie. But you know what? It was never about their jobs. It was never about the clinic. It was always about the uninsured. And the facts are, numerically, that the patient population that we've been serving have enrolled their kids into My Child, because I had given clear instruction to our social workers over the years to get the kids enrolled, and I have had repeated conversations back from them saying, would you quit bugging me? They already have their kids enrolled. So that was a clear thing. Once the Family Health Center's hours expanded and the money came in so they could hire more providers, our patients have left the free clinic episodic model to a medical home, which I think is intuitive. I mean, they know what medical means. They never got my phrase when I said, you need a primary care provider. They'd look at me like, sure, And, you know, I've been saying it over and over, and they never got it. Now when I say medical home, oh, there is such a thing. How do I get there? What does it look like? Where is it? Give me the contact information, and I'm out of here.
So
And they've been out of here.
So just for those of you who didn't follow all of that background, Jane's run a free clinic in the Kalamazoo area for how many years? 17 years. And they've just made the decision to effectively close their doors and transition their patients to the federally qualified
And
health
the
center.
patients already have transitioned themselves,
Right.
Marion, which is,
Right.
you know, they've done it on their own.
Yeah.
It's very cool.
It's been, but with your help. So it's been a fabulous and I think interesting model for us to think about for the future. Other questions? Yes, in the back there.
Sister Phyllis Klonuski, I'm a pharmacist that's worked for the better part of the last 10 years with a free pharmacy associated with the free clinics as well as the FQHC and the physicians' clinics and 2 hospitals in the Saginaw area. So I'm drawing on a mixed background. There are a couple of observations as well as questions. I am willing to add the observation, and anyone here can add or subtract from it. But regardless of free clinic, complicated patients in your clinic, doctor, HQFCs, one of the key concerns is medication for probably 98, if not 99% of the people being treated, whether acute or chronic. And one of the biggest concerns that I have seen, and I just came from a day-and-a-half meeting looking at this from the pharmacy perspective, even IT doesn't see why pharmacy should be able to communicate back and forth, even though electronically, if something starts on the computer, it's got to follow through. But one of the things that I've found, whether it's somebody that can transition to the FQIC or because of medical or family or other conditions can't, one of the key things that I have noticed over the 10 years, and my staff keeps bringing back to me, is an element of a person that develops a relationship with that person, and that might be the person that sits in the waiting area and welcomes them and signs them in. This does not need to be the doctor at the opposite end. One of the key things is a trust, not only with the location, but with the staff. And that's critical the more complex the medical and mental health composite goes there, because these are the people that have been bounced, whether being dropped by Medicaid, the county health plans, Medicare, and they don't understand. So the need for reinforcement and relationship, and for a team to understand what needs and where is the red flag to alert somebody up the line, is something that's critical. And it doesn't mean you have to give full medical history, but it is a key component to this,
Right.
to bridge the fragmentation. I think the element of honestly thinking outside of the box as we move forward, because IT is by no means clean on what is needed, and the providers don't know what to do with it. I mean, the technology people. We need to think in view of the information security. What are key elements of support or flag that you need to get a person back, even if it's for 5 minutes to meet with a pharmacist or a technician or pick up a med, if it means coming weekly to get meds? What is the point of a trigger that can go on a computer screen, not violate your confidentiality, but give that person a support. But further, how many of us ask at some place along the line, the patient or their caregiver, what would help you buy in? Is it the phone call? Is it coming more frequently to get something? Is it just something to help me remember? What is it that you need to buy into this and
Great.
contribute to it?
That's great. Thank you. And I think actually, Peter, you did sort of run across some of that same sentiment in your interviews.
A couple quick points. We did, and the project team has talked a lot about that function of leadership, culture, and the interpersonal relations. That was a fairly consistent theme that has an effect on efficiencies and ultimately patient satisfaction. I would say that there was a lot of skepticism, not just among free clinics, but other clinic types about being a patient home, a patient-centered medical home, regardless of the clinic type. Some were more cynical than others, saying, well, this is what we've been doing all the time, so we'll just call ourselves a patient-centered medical home. But I think we run the risk of worrying about labels and not the core of why we need a safety net and what we want the safety net to do.
Great. Thank you. Okay, I am going to add, oh, we have one more? Okay, one more, and then we'll switch up the reactor panel and the this panel.
Thank you. Hi, Jimetta Lilly, the project director for the Wayne Children's Healthcare Access Program. We are a pilot initiative to adapt a model wherein we will work in partnership with community-based programs, PCPs, et cetera, to increase children's health outcomes as well as have a return on an investment. A question, and I was very intrigued and pleased to hear the conversation about fragmentation of services. Because we all know, whether that's intra or inter, our systems don't talk to each other, but our units within those systems don't talk to each other as well, and we know what the outcome of that has been. I'm wondering, though, even when I look at our setting here, which is so incredibly important as we talk about transformation as a result of the opportunities of healthcare, if the panel could speak to how might we begin to have these same kind of conversations about improving care coordination, continuity, with members of that entire circle that touches the family, whether in our case it would be children and youth or adults. The absence of social services at the system from a systemic perspective, the absence of mental health from a systemic perspective, as we talk about building an infrastructure that can facilitate systems change to get to where we want to go. It seems that we're still in our silos. Health is talking about this new transformation. But we need to make sure that we are linking that to the changes that are occurring in education. How do we bring along our folks in social services, et cetera? Just like to hear some of your thoughts about that.
You want to start because the fairly qualified health centers were, I mean, that is part of their philosophy, yes?
Well, yeah, I mean, the question that you ask is, you know, sort of the question for the ages. I was in a discussion with somebody a number of weeks ago now who runs a very interesting project in Camden, New Jersey called the Camden Project. And through a remarkable effort to secure hospital discharge data, this small project mapped every discharge in Camden, New Jersey. It was there were 3 major hospitals in Camden, New Jersey. They gave this group all their data, they mapped it, and what they discovered, of course, was that the vast majority of health bills were traceable to certain neighborhoods, to certain patients. One particularly interesting cluster of discharges involving dual enrollees. All traced to a single assisted living project for elderly, very low-income people in Camden. The project had been poorly run, and they finally got a terrific public housing project director who simply put grab rails up everywhere, and all the admissions stopped.
Wow.
So the question is, how one gets to that, listening to Brent's description of the most complex patients who have tremendous physical conditions overlaid with tremendous emotional, behavioral, social conditions. And yet at the same time, even for the sickest patients, I think the lesson from this is that it's often relatively modest adjustments in life that may make the biggest difference. And I think that one of the great hopes out of the Affordable Care Act, it's going to be a long time coming, but nonetheless you can sort of see this clumsy trajectory that the law contains, to try and get public health resources working much better with community health care resources, whether they're primary care resources or the sort of advanced care resources. Why don't all public health agencies have geomapping? Why don't all hospitals give all of their discharge data, their emergency department and their hospital discharge data, to public health agencies so that they can do micro-mapping to start tackling, one diagnosis at a time, these kinds of problems. For children, the number one discharge and emergency department problem nationwide is asthma. And we don't have any way of being able to say to the free clinics or community health centers or any other group here in Michigan, okay, you guys are in the neighborhoods that experienced $71 million worth of discharges. And here are the treatment guidelines which include the really good treatment guidelines, are not just about the inhaler, it's about the environmental pest reduction and case management for the most severe cases and social change. All of that would be much cheaper than the $71 million. Now, build an ACO around childhood asthma with free clinics, community health centers, and the hospital systems that are seeing these cases, and you work out a Medicaid, as they call it, gain-sharing arrangement around pediatric hospital discharges, and now maybe you're putting some money in the kitty for the kinds of investments that will drive the hospitalization rates down, but let everybody actually realize some of the savings for social investment. I think that's the great promise of ACOs, is that they actually contemplate some social investment through realized savings. And because the federal and state governments cannot just pocket the savings, they have to reinvest the money. And so what I would be doing is using the kind of geomapping that Camden was using to find the most expensive discharges, the most expensive ED diagnoses, do the social diagnosis that lets you figure out what kinds of investments you would have to make to offset the expenditures and negotiate your savings. I mean, that I think is where the Affordable Care Act opens some doors. So,
Right. Anybody want to add?
I agree with that, and we go somewhat further and start a conversation about integrating public health and the medical care system into one system rather than two separate systems. Second, one-stop shopping for social services, so that I go to one place where I can derive eligibility for whatever my social needs are. And third, there's this sense of ownership of the problem. And that gets back to educating individuals. And helping them to navigate and be able to avoid some of these problems. But fourth, we do a lousy job of sharing knowledge. So look at how many bits of information that we've heard about from different programs. Where can you go to find that? Where? You can't. Why not? So we need much better sharing of information so that you can build the systems that Sarah's talking about.
I should note one last thing. When I asked this guy who'd done this remarkable work in Camden. I said, so where did you get the funding to do the research? I mean, was this an ARC grant? I figured this was several $100,000 worth of work. He said, he's a very clever guy. He said, nah, I got a couple of computer students, and for $20,000 we built a program that read the data, got the hospitals to cooperate with us, did the analysis.
That's great. Great. Want to add anything?
I do. Thank you.
Good. Good.
And I'm going to address it from the perspective not so much of what might be under the ACO or what likely will be or even what ought to be under the ACO, but what can be. And I'm going to say three things. The first is, don't wait for the ACO and the PCMH to solve this. The world is, regardless of what happens through midterm elections and what we see on the far side, the world is going to remain balkanized in some important fundamental ways. Period. Number two, do stuff now. IT comes to mind. Do stuff now to try to weave things together. So we've had some success at punching holes in IT firewalls between St. Joe's and the University of Michigan, between the Shelter Clinic and us, between our Packard Health and the University of Michigan. It takes time and energy and lots of paperwork and lots of credentialing and assurances and all this stuff. But it can be done if you stick at it, stick with it. So work with what you've got now to cross barriers between systems. That's number two. Number three is care management is probably going to be at the center of it. So even across institutions, I think it's vital to have one pluripotential care manager who knows people in a lot of different places. We've had, I think, a lot of success with our care managers getting on the phone. We have cross-institutional meetings twice monthly to get people knowing each other face to face. And so a care manager can talk to somebody at another institution and because they know them by name. They know what their services are. They come regularly around to us and tell us what the range of social services is. But within this care management thing, my personal mantra is that there needs to be just one, right? There really needs to be someone with ownership of the patient. Partnership with the patient is a better phrase with it. And not because one of the problems is you have a care manager at community mental health, you have a care manager at the hospital, you have a care manager at the shelter, you have a care manager. None of them takes prime responsibility for coordinating the overall care of those patients. You can do that with a little community consensus building around the mechanics of how that works.
Great. Thank you. All right, we're going to switch up here and